I want to tell you about a patient of mine. His name is Richard. Richard is 72 years old, and he came to see me 6 months ago with a piece of paper in his hand, an echocardiogram report that his cardiologist had ordered and that he had received in the mail 3 days earlier and had been reading and rereading and not understanding every night since. He sat down in my office and he put the report on the desk and he pointed to a phrase that appeared 3 times in the summary section: left ventricular hypertrophy. And he said, "Dr. Chen, what does this mean? My cardiologist told me the walls of my heart are thickening and that I need to control my blood pressure better." And that was it. That was the entire explanation. And I said, "Richard, I am going to explain everything on that report in a way that leaves you understanding exactly what is happening inside your heart, why it happened, what it means for your future, and what we are going to do about it. Because you deserve that explanation, and it should not have taken coming to see a second doctor to get it." Now, before I tell you what I told Richard, let me give you some numbers from his echocardiogram, because the numbers are what make this real. Richard's interventricular septal wall thickness, the wall between the 2 sides of his heart, was 13 millimeters. Normal is below 12 millimeters. His posterior wall thickness was 12.5 millimeters. Normal is below 12 millimeters. His left ventricular mass index, a measure of the total mass of his heart's main pumping chamber, was 118 grams per meter squared. Normal for a man is below 115 grams per meter squared. His ejection fraction, the percentage of blood the heart pumps out with each contraction, was 58%, which is technically normal. Above 55 is considered normal. But he had something else on his report that his cardiologist had mentioned, but not explained: grade 1 diastolic dysfunction. And those 4 words, combined with the words left ventricular hypertrophy, were what had sent Richard home with that report, reading it at the kitchen table every night, not sleeping, trying to understand what was happening to the muscle that had been beating in his chest every single minute of his 72 years. I am Dr. Daniel Chen, and today I want to explain left ventricular hypertrophy, what it is, why it happens, what it means, what the connection is between blood pressure and the thickening heart muscle that shows up on an echocardiogram, and what every adult over 65 with a history of high blood pressure needs to understand about what may be happening inside their heart right now, whether they know it or not. So let me start at the very beginning with what the left ventricle is and why it matters so much. Your heart has 4 chambers: the right atrium, the right ventricle, the left atrium, and the left ventricle. The left ventricle is the largest and most powerful of the 4 chambers. It is the main pumping chamber of the heart. With every heartbeat, the left ventricle contracts powerfully, generating the pressure that drives blood out through the aorta and through the entire arterial system to every organ and tissue in the body. Now, the amount of pressure that the left ventricle needs to generate with every beat depends on how much resistance the arterial system is presenting to the outflow of blood. In a person with normal blood pressure and elastic, compliant arteries, the resistance is manageable. The left ventricle pumps against that resistance with the force it was designed for. But when blood pressure is elevated, when the arteries are stiffer, when the resistance the left ventricle must pump against is consistently higher than normal, the left ventricle has to work harder with every single beat. to generate enough pressure to push blood through that higher resistance. And when a muscle works harder than it was designed to work consistently over months and years and decades, it responds the way all muscles respond to sustained overload. It gets bigger, it gets thicker. This is called hypertrophy. And in the heart, specifically in the left ventricle, it is called left ventricular hypertrophy, or LVH. The walls of the left ventricle thicken because the individual muscle cells, the cardiomyocytes, increase in size in response to the demand of consistently pumping against elevated pressure. And what shows up on Richard's echocardiogram, those thickened walls, that increased left ventricular mass, is the physical record of years of elevated blood pressure written into the muscle of his heart. Richard's blood pressure had been elevated for over a decade before he was diagnosed and even after diagnosis. It had been incompletely controlled for several years before his current medications had brought it to a better level. And the heart, all through those years, had been quietly responding to the extra load it was carrying by doing what muscles do when they are chronically overloaded, getting thicker, getting heavier, and changing in ways that have consequences that go beyond simply becoming bigger. Because here's what most people, including many doctors, do not fully explain when they deliver a diagnosis of LVH. The thickening of the left ventricular wall is not simply a larger version of a normal heart muscle. It is a structurally and functionally different heart muscle. And the differences matter profoundly for long-term health. The first functional change in a thickened left ventricle is what Richard's report described as diastolic dysfunction. Diastole is the phase of the cardiac cycle when the heart relaxes between beats, when the ventricle fills with blood from the atrium above it. In a normal healthy heart, the left ventricular muscle relaxes rapidly and fully after each contraction. The ventricle fills easily and completely with blood from the left atrium at relatively low pressure. But in a hypertrophied heart, the thickened muscle is less compliant, less able to relax fully between beats. The stiff, thickened walls resist the filling of the ventricle, and the heart has to generate higher filling pressures to bring the same amount of blood into the ventricle as a normal, compliant heart would accept at much lower pressure. This is diastolic dysfunction. The heart contracts normally. Its ejection fraction, as Richard's report showed, is preserved at 58%. The squeezing function looks fine, but the relaxation, the filling, is impaired. And this distinction between preserved ejection fraction and impaired diastolic function is clinically crucial because it is the mechanism behind one of the most common and most under-recognized forms of heart failure in older adults, called heart failure with preserved ejection fraction, or HFpEF, and diastolic dysfunction. On an echocardiogram is one of the earliest and most important warning signs that this condition may be developing. The second functional change in a hypertrophied heart is increased oxygen demand. A larger, heavier heart muscle requires more oxygen to function than a normal heart does. And this increased oxygen demand in the context of coronary arteries that may themselves have been affected by years of high blood pressure and atherosclerosis creates a mismatch between the oxygen the heart needs and the oxygen the coronary blood supply can deliver, particularly during exertion when demand rises further. This mismatch is one of the mechanisms by which LVH increases the risk of angina and heart attack in affected individuals. The third functional change is electrical instability. The electrical conduction system of the heart that coordinates the precise timing of each contraction runs through the walls of the cardiac chambers. When those walls are thickened and when the muscle structure is altered by hypertrophy, the electrical pathways can be disrupted, creating areas of abnormal electrical conduction that predispose to arrhythmias, irregular heart rhythms, including atrial fibrillation, which is already significantly more common after 65, and which, in the context of LVH, is both more likely to develop and more difficult to manage when it does. And ventricular arrhythmias, which in severe LVH can increase the risk of sudden cardiac death. Research has consistently shown that LVH is an independent risk factor for cardiovascular events, including heart attack, stroke, heart failure, and sudden cardiac death. A meta-analysis published in the Journal of the American College of Cardiology found that left ventricular hypertrophy was associated with a 2 to 3-fold increase in cardiovascular mortality compared to individuals without LVH, even after accounting for blood pressure levels and other risk factors. This means that LVH is not simply a marker of poorly controlled blood pressure. It is itself an independent predictor of cardiovascular risk that needs to be treated and monitored as a condition in its own right. Now, let me tell you something that Richard did not know when he came to see me. And that, I think, is one of the most important and most hopeful things about LVH. LVH is partially reversible, not fully and not quickly, but meaningfully with sustained, aggressive blood pressure control. The hypertrophied left ventricle can regress, the walls can thin, the mass can reduce, the diastolic function can improve. Research has shown that effective blood pressure treatment with the right medications can produce meaningful reductions in left ventricular mass over 12 to 24 months of sustained control. A landmark meta-analysis published in the Journal of the American Medical Association examined 80 randomized controlled trials and found that antihypertensive treatment significantly reduced left ventricular mass index across all major drug classes, with the greatest regression seen with ACE inhibitors, ARBs, and calcium channel blockers. Specifically, the same classes of medications that Richard was already taking for his blood pressure. This means that the thickening Richard saw on his report is not a fixed verdict on the health of his heart. It is a reversible finding that responds to exactly the treatment that he is now on. If that treatment is sufficiently aggressive and sufficiently sustained, Richard's left ventricular mass can reduce, his diastolic function can improve, and his risk of the cardiovascular events associated with LVH can decline, not to zero, but meaningfully. And that is not a small thing. That is the difference between a condition that is simply managed and a condition that is genuinely improving. Now, let me also explain what the management of LVH actually involves, beyond blood pressure control. Because blood pressure control is the most important element, but not the only one. The first priority is achieving and sustaining blood pressure targets that are lower than the targets that might be used for someone without LVH. For Richard, with LVH and diastolic dysfunction, the target we discussed was a systolic blood pressure below 120 millimeters of mercury on consistent monitoring. Not just occasionally, but consistently over months, because LVH regression requires sustained pressure reduction, not intermittent or partial control. The second element is sodium restriction, as I have discussed in my videos on blood pressure and on evening meals. Sodium directly raises blood pressure through fluid retention mechanisms, and in the context of a heart that is already working against elevated resistance. Reducing the sodium burden on that heart is a direct and meaningful intervention for Richard. We discussed reducing his sodium intake to below 1,500 milligrams per day, a significant reduction from his current intake, but one that is achievable with specific attention to the processed and packaged foods that contribute the majority of dietary sodium in most older adults' diets. The third element is aerobic exercise, specifically moderate intensity aerobic activity. Research has shown that regular aerobic exercise independently reduces left ventricular mass in individuals with LVH through mechanisms that are separate from and additional to the blood pressure lowering effects of exercise alone. For Richard, the advice was 30 minutes of moderate walking 5 days per week at a pace that elevates his heart rate but allows him to maintain a conversation without breathlessness. The fourth element is weight management, if relevant. Obesity, particularly central obesity, is an independent contributor to LVH through multiple mechanisms, including elevated cardiac output required to supply a larger body mass and the neurohormonal activation associated with obesity that directly drives cardiac remodeling. For patients with significant obesity and LVH, weight reduction independently reduces left ventricular mass separate from its effects on blood pressure. The fifth element is specific medication choice. Not all blood pressure medications produce the same degree of LVH regression, even at equivalent blood pressure reduction. ACE inhibitors and ARBs have shown the greatest and most consistent LVH regressing effect in the research. And for patients with LVH and diastolic dysfunction, these classes of medications are typically preferred over other options if they are tolerated. Richard was already on lisinopril, which is an ACE inhibitor, and we discussed whether the dose was adequate to achieve the more aggressive blood pressure target we had set and adjusted accordingly. The sixth element is regular echocardiographic monitoring to track whether the LVH is responding to treatment or progressing despite it. An echocardiogram repeated at 12 to 18 months after optimizing treatment shows whether left ventricular mass is reducing, whether diastolic function is improving, and whether the treatment plan needs to be adjusted. For Richard, we scheduled a repeat echocardiogram in 12 months with the expectation that if his blood pressure was consistently below 120 systolic, we might begin to see some reduction in his left ventricular mass on that repeat scan. Richard sat with all of this for a moment, and then he said something that I want to share with you because it captures what the experience of receiving a diagnosis like this without an adequate explanation actually feels like for a patient. He said, "Dr. Chen, I have been walking around for 3 days with that report, thinking I was dying because nobody explained to me what those words meant. And now that I understand what is happening and why, and what we can actually do, I feel like I have my life back. Not because the news is good, the news is not good, but because I understand it now. And understanding something is the first step toward doing something about it. And that is everything." Let me bring everything together now. Left ventricular hypertrophy is a thickening of the wall of the heart's main pumping chamber, caused primarily by sustained elevation of blood pressure over months to decades. It is the heart's response to consistently pumping against higher resistance than it was designed for, getting bigger and thicker in response to chronic overload. The thickened heart muscle is less compliant, less able to relax fully between beats, producing diastolic dysfunction, the impaired filling that is the earliest sign of what can progress to heart failure. With preserved ejection fraction, LVH also increases the heart's oxygen demand, creates electrical instability that predisposes to arrhythmia, and is an independent risk factor for cardiovascular events, including heart attack, stroke, heart failure, and sudden cardiac death, associated with a 2 to 3-fold increase in cardiovascular mortality in the research. But LVH is also partially reversible with sustained aggressive blood pressure control using ACE inhibitors or ARBs preferentially, combined with sodium restriction, regular moderate aerobic exercise, weight management where relevant, and regular echocardiographic monitoring to track regression over time. Richard's heart was telling him something through that echocardiogram report that his blood pressure readings alone had never been able to show him. It was telling him that the years of elevated pressure had left a mark on the muscle that had been working every minute of his 72 years, without rest, without complaint. And now he knew. And knowing was the beginning of doing something about it. If you are over 65 and you have a history of high blood pressure that has not always been perfectly controlled, please ask your doctor whether an echocardiogram is appropriate for you to assess whether any degree of left ventricular changes may have occurred over the years of that elevated pressure. You can say, given my history of high blood pressure, I would like to discuss whether an echocardiogram to assess for left ventricular hypertrophy would be appropriate. That is a completely reasonable and clinically informed request, and the answer may change how aggressively your blood pressure is managed going forward. I am Dr. Daniel Chen. If this video finally explained something on a medical report that a doctor handed you without a proper explanation, please share it with someone over 65 who has high blood pressure and who has never been told what that pressure may be quietly doing to the muscle of their heart. Subscribe to this channel for weekly videos made with genuine care for older adults who deserve real information about their own health. And leave me a comment below. Tell me whether you have ever had an echocardiogram and whether anyone has ever explained to you what left ventricular hypertrophy actually means. I read every single comment, and I genuinely look forward to hearing from you. Take care of your heart. It has been working for you every single minute of every single day of your entire life. It deserves to be understood and protected with everything you have.